l'immense bonheur, l'immense plaisir et l'honneur surtout de recevoir une personne que tout le monde connaît, le professeur Nora VOLKOW. Évidemment, je ne vous ferai pas l'insulte de vous dire de qui il s'agit, mais simplement vous raconter l'histoire par laquelle elle a réussi à venir. Ça fait quelques années, je me suis retrouvé dans un congrès qui s'appelle le CPDD avec Jean-Pierre Dolouet, il y a je crois une quinzaine d'années, et puis il m'avait emmené écouter Nora VOLKOW dans une conférence comme elle le fait. Elle fait rituellement une grande conférence au CPDD, une grande conférence à l'APA. Et donc j'avais dit à Jean-Pierre, ça serait bien qu'une fois, dans notre vie, on puisse pouvoir demander à Nora VOLKOW de faire la même chose en France. Et ça fait à peu près 10 ans que je l'invite régulièrement au congrès de l'Albatros. 10 ans, de manière rituelle, comme ça. Évidemment, une fois elle était en Suède, à l'Académie des sciences, une fois elle était avec le président Obama, je me souviens. Et puis cette année, elle a répondu oui. Elle va vous dire pourquoi elle a répondu oui. Je ne sais pas pourquoi. Pour moi, c'est une énigme, mais tant mieux. Tant mieux. Alors évidemment, comme mon complice de toujours, c'est le docteur Jean-Pierre Dolouet, évidemment, je lui dis, puisqu'elle est là, tu te débrouilles. Voilà, donc il a mis une cravate, vous l'avez remarqué. Et je voudrais m'arrêter en citant et en rendant hommage à un homme exceptionnel qui n'est pas aujourd'hui ici, qui aurait aimé être avec nous, c'est le professeur Charles O'Brien. Je vous demande tous de l'applaudir parce que c'est grâce à lui que ce congrès existe. Je vous dis ça parce que lorsque je commençais à inviter quelques collègues américains, tous allaient vers lui en lui disant qui c'est lui. Et donc ils disaient vous pouvez y aller, c'est des amis. Voilà pour cette petite histoire de détente avant de donner la parole à Jean-Pierre.
Merci, Ami. Donc c'est en effet un honneur et un grand bonheur de recevoir donc, le docteur Nora VOLKOW. L'introduction, on ne présente pas Nora VOLKOW, simplement on peut présenter sa conférence. On pourrait passer toute la session à rapporter les grandes étapes de son œuvre scientifique, administrative. On va simplement rappeler qu'elle est médecin psychiatre, chercheur en neurosciences. Elle est d'origine mexicaine et elle est actuellement, depuis l'année 2003, la directrice du National Institute on Drug Abuse américain et qui est un des dynamiques instituts du NIH américain. Elle a commencé ses études, elle a fait ses études de médecine au Mexique, à l'Université nationale du Mexique, et elle me rappelait qu'elle a passé une année de médecine à Sainte-Anne, à Paris, dans le service du professeur Pierre Pichot. Elle était aussi très en contact avec le professeur Denis Kerr, et où elle est venue étudier, non pas les neurosciences, mais la phénoménologie. C'est intéressant à la phénoménologie, cette branche philosophique de la psychiatrie, et c'est amusant, intéressant de le rappeler, car sa carrière scientifique, la suite ne le sait pas forcément. Imaginez qu'elle avait abordé cet aspect de la science psychologique et psychiatrique. Donc l'histoire dit qu'elle est partie ensuite, alors ça n'est pas l'histoire qui dit, c'est les faits, elle a fait sa résidence aux États-Unis, à New York, sa résidence de psychiatrie, elle est devenue psychiatre, et à la fin de cette résidence, l'histoire dit que c'est à la lecture d'un article exposant les possibilités qu'offraient les PET scans qu'elle a décidé de poursuivre sa carrière en l'orientant vers la recherche dans les neurosciences et la recherche sur le cerveau. Elle a donc travaillé pendant de longues années au Brookhaven National Laboratory, où elle a produit des travaux très importants et très intéressants à partir de l'imagerie cérébrale et donc des troubles fonctionnels avec un éclairage et des apports très considérables sur la connaissance donc des troubles fonctionnels en lien avec les consommations de substances, mais aussi avec les addictions sans substance. Donc, elle est évidemment auteure de très nombreux articles, livres, etc., dans les articles dans les meilleures revues. Et on va pas rapporter les très nombreux awards qu'elle a reçus. Ils sont évidemment très nombreux. Rappelons simplement qu'elle a été en 2009 lauréate du prix international de l'INSERM. Et ça c'est pour les auteurs français, mais il y en a une multitude d'autres. Simplement, concernant ça, j'allais dire pour la petite histoire, mais dans le cas de Nora, la petite histoire, c'est la grande histoire, c'est l'histoire tout court, puisqu'elle est l'arrière-petite-fille de Léon Trotsky, et qu'avec ses sœurs, elle a grandi, elle a été élevée dans la maison donc, de son arrière-grand-père, où il a été assassiné en 1940, donc par les sbires de Staline, et elle a grandi donc, dans leur maison de Coyoacán, à Mexico. Et donc, je crois qu'elle conserve de cette prestigieuse ascendance, de cette lignée, le goût de servir l'humanité, et elle a choisi de le faire, cette amélioration du sort de l'humanité, qu'on lui a enseigné depuis toujours, à travers la science, comme facteur de liberté et d'amélioration de la condition humaine. Nora, tu as la parole. Chair is yours.
Bonjour Jean-Pierre, merci beaucoup et je vais te répondre. Je suis venue ici parce que j'étais vraiment impressionnée par la passion et la détermination que tu as pour rendre ce congrès un grand succès. So, merci beaucoup pour m'avoir invité ici et pour me donner la parole cette fois. Je vais parler en anglais parce que je ne connais pas les mots en français non plus, ils m'échappent. Alors c'est beaucoup plus facile pour moi de parler en anglais, so je suis dommage, but I'm shifting into English. In France, I think that there's one of the aspects that made it also very appealing for me to come here and present is that in France there's a true sense of the medical establishment recognizing that it is important to treat addiction and that physicians are very, whether they are psychiatrists, the specialty, or neurologists or other specialties, can actually help patients suffering from addiction. Whereas in the United States, this has been much, much slower in coming, but that is starting to change. And what is changing is a tragedy that is occurring right now in the United States that we refer to as the opioid crisis. And because things actually right now transpire very rapidly, what I want to tell you the story of what we are observing in the United States and how we are using science to try to solve it is something that I also want to send a message in order for you as a country to not allow this to happen. Because the epidemic that we're currently observing, initially with prescription opioids, but now with heroin and fentanyl, is something that can rapidly occur in other areas of the world and that happen in the United States very, very rapidly. So what is the opioid crisis and how bad it is? You are seeing geographical maps of the United States displaying in different colors the rate of overdose fatalities as a function of 100,000 individuals. And you can see that in 1999, the colors are the temperature scale. So the spots that are red are the areas which have very high rates of mortality from overdoses. In 1999, these were restricted to 2 small regions in the United States. And you can advance 17 years later, and you can see how it has disseminated across all of the United States. And the rates of overdose fatalities basically have more than quadrupled during that period of time. And so the question is, what drove this opioid crisis? And it's a simple answer. We know it. It was, number one, the overprescription of opioids. Now, of course, you can ask the question, what drove the overprescription of opioids? And there are multiple factors. One of the factors was the good intentions of physicians to try to treat patients suffering from pain without proper understanding and knowledge about how to properly treat them and how to properly prescribe opioids. At the same time, there was a very strong campaign, in part through pharmaceutical industry, to disseminate the notion that if you use opioids for someone that has pain, they are non-addictive, and also the sense that you can raise the doses of opioids without being concerned about respiratory overdoses, respiratory depression. So those two aspects, this facilitated the overprescription of very large doses of opioids, which were then diverted and people became addicted to them, or patients who were prescribed these medications became addicted to them. And why is that so? Well, this is an image obtained with positron emission tomography and C11 carfentanil, and it measures the concentration of mu-opioid receptors in the human brain. It's a three-dimensional rendering, the same color scale, the temperature scale, showing in red the areas with the highest concentration. And the areas that have the highest concentration of mu-opioid receptors actually are regions that form part of what we now recognize by the name of the pain network. The anterior cingulate cortex, ACC, the thalamus, the periaqueductal gray, and to a lesser extent, also very high concentration, the amygdala. And the amygdala is the area of the brain that poses the emotional negative affect to the perception of pain. All of those regions are loaded with mu-opioid receptors. An opioid agonist, which we use to treat pain, such as morphine, oxycontin, hydrocodone, all of them inhibit these regions, and so the basically blocking the sensation of pain. But there's very high concentration of mu-opioid receptors in the nucleus accumbens, and that is the main reward center of the brain. And it actually also in the ventral tegmental area of the brain, which is where you have the location of the dopamine cells that release dopamine into the nucleus accumbens. So opioid agonists, whether it is morphine or Vicodin or any of the analgesics, or it's heroin or fentanyl, all of them release dopamine in the nucleus accumbens, activating it. And this is, of course, as we all know, this is a common pharmacological effect of all of the drugs of abuse that can produce addiction. And there lies the paradigm and one of the big challenges, that we have drugs that are very, very effective in controlling severe pain. There's no other drug that can produce immediate relief of intense pain, yet at the same time are highly rewarding. And in the United States, the practice of compliance that led many to overprescribe opioids did not recognize another problem with the opioids when managing pain, and that is that you become rapidly tolerant to the analgesic effects. And that means that with repeated administration, you require higher and higher doses. And the higher the doses that you require, the greater the risk for addiction on the one side, but also the greater the risk for respiratory depression, because there are also opioid receptors in the brainstem, which is where the nucleus that controls our breathing is located. And mu agonists inhibit the firing of the neurons that make us breathe. And because the tolerance to the effects of these opioid agonists differs, for example, you do not become tolerant to the constipation effects of opioid agonists, whereas you rapidly become tolerant to its analgesic and rewarding effects. And the effects on respiratory depression are intermediary, and that explains why, as you increase the doses, and now we know, for example, there is very high risk of overdoses, at least fourfold higher risk for doses of 100 morphine milligram equivalents or higher. So those practices that initially were guided by the sense that these were very safe drugs are now being questioned with the notion of how do you use, in an acute situation, opioids are life-saving. But when it comes to the management of chronic pain, the question is to which patients are they going to be most beneficial, and what doses and regimes should be utilized to minimize the likelihood that patients become addicted to their medications and that they actually still have some relief from their pain. And that, curiously, we've come to realize is an area that has been under-investigated. What do we know about opioids? We know that they activate dopamine cells, the VTA, and that they release dopamine in the nucleus accumbens. And interestingly, both from studies that have been done in animal models of where you self-administer, the animals are learned to self-administer the drug, or the investigators give them the drug repeatedly, as well as from individuals, heroin users that overdose and die. One of the things that has been recognized is that the repeated use of opioids leads to a decrease in the volume of the dopamine cells. And you can see it actually, those are cells from someone that died, a heroin overdose, and you can see the decrease in the volume of these dopamine cells that are also become hypofunctional. They release much less dopamine. And the decreases in release of dopamine, for example, is one of the phenomena that we have also observed in patients that are abusing and addicted to cocaine. And we have also seen it in patients that are addicted to alcohol. Because it has not been investigated across all of the drugs of abuse, we do not know if this is a general phenomena. But we certainly do know that in the case of heroin, as well as other opioids like morphine, repeated administration results in a downregulation of the dopamine system, which is, of course, the one that leads and motivates our actions and incentivizes our everyday activities. Through also, in this case, initially documented through imaging research and then replicated in animal models of drug self-administration, we now know also not only is there a decrease in the amount of dopamine release that occurs with opioids and other drugs, but also we know that there is a downregulation of dopamine D2 receptors. As you know, dopamine signals through dopamine receptors, and there are 5 different types of them. The most investigated and the most relevant in terms of the addiction and the rewarding effects of drugs are the dopamine D1, the dopamine D2, and to a lesser extent, but also just because it is much more restricted in its expression, the dopamine D3 receptors. We know now that the function of these, in particular, most of the work has been done with the D1 and the D2 receptors. When they signal by dopamine, they have almost opposite effects. And we now know that dopamine D1 signaling by the increases in dopamine produced by drugs is what is indispensable for the drugs to be rewarding. And it is that stimulation by the D1 receptors that ultimately triggers the neuroadaptations that result in conditioning, neuroplasticity, and sensitization. On the other hand, what we're observing is that the dopamine D2 receptor is a receptor system that enables us to regulate our movement, our reward, and motivation. So in a short way, controlling precisely the signaling that is coming from the dopamine D1. And we have been observing in multiple independent studies that we've done in cocaine abusers, methamphetamine abusers, alcoholics, heroin abusers, individuals addicted to nicotine. Across all of these addictions, we have been able to document a downregulation of dopamine D2 receptors. And so this is the receptor system that allows the juxtaposition to the D1 signaling, which is the one necessary for the rewarding effects of drugs. And this down degradation of the dopamine D2 receptors, we have known actually, and others, again, this has been documented by multiple investigators in laboratory animals. And in laboratory animals, because the question is, what is the significance of this downregulation of D2 receptors? From laboratory animals, for example, we know from Trevor Robbins that if you have low levels of dopamine D2 receptors, those animals are much more impulsive and will readily lead into compulsive self-administration of cocaine, as opposed to animals that have high levels of dopamine D2 receptors. We have in our laboratory also, in animals that are addicted, upregulated the dopamine D2 receptors and observed what happens to their drug intake. And what we have observed, and so have others, is that there is a decrease in the amount of drugs that animals self-administer when you upregulate the dopamine D2 receptors. And in humans, we now know that this is mediated, the regulation of the D2 receptor system is mediated in part by the modulation that the dopamine D2 receptors in the striatum have on the prefrontal cortex. And so as the D2 receptors actually are downregulated by repeated drug exposure, the ability of the prefrontal cortex to exert self-inhibition and self-regulation is jeopardized. So we know then that heroin, like any other drug, produces it. And this, I want to show you this map because it does give you an idea of the origin of the crisis. And I do believe that we can learn from history. We may choose to ignore it, but my perspective is in looking at what has happened is that we should pay attention to it. The two countries that have the highest rates of mortality right now facing opioids are the United States and heroin, and their sizes here are reflected by the number of prescriptions that are given vis-a-vis the oversize is vis-a-vis the standard of what the need of benefit from those medications are. And the United States clearly is over-prescribing. In 2011, at the peak of prescriptions, we have more than 200 million prescriptions in that year for hydrocodone or oxycodone-like compounds. Sufficient medication to treat every single adult American with an opioid for 1 month. So that gets you an idea of where the overprescription practices, and that, of course, facilitated its diversion. Intriguingly, because as we are discussing this issue, and to the extent that some of the patients that are given opioids become addicted to them, and it's a very challenging one, independent of that, we need to recognize that patients suffering from pain, in particular suffering from chronic pain, actually require proper treatment. And if we do not properly treat them, we know that there will always be a black market for this type of drugs. Unfortunately, despite the high prevalence of pain, because pain is associated with almost every single medical condition that we know of, including mental illness, depression and pain are highly comorbid. We see that despite the impact of the prevalence of this disorder, when you compare it with other, the level of investments from venture funds to develop medications has been very, very minimal. And this, again, reflects multiple facts, including the notion if you have opioids and you're actually prescribing them and are being reimbursed for those prescriptions, why would you want to have another medication that is going to compete with your own product? So there have been the wrong incentives. So we need, this is one of the areas that we're very aware that we need attention to. But it's not just, as I said, about opioid prescriptions. That's what initiated it. But see how the transition that I mentioned to you into heroin happens in 2011, and see how the transition into the synthetic opioids started to be evident at the beginning of at the end of the 2013. And see how rapidly these are number of fatal overdoses. And this is why I bring it to your attention. Pay attention to the fentanyl, and it's not just fentanyl. This is not therapeutic fentanyl. This is a fentanyl that comes, it's believed, predominantly from China, from black markets. It's fentanyl and other synthetic fentanyls, including carfentanil. And what has happened is, whereas in the United States we did not have a problem of fentanyl, as heroin became more widely available of a higher purity, there was a market for people that became addicted to the opioids that then was very easy to fulfill with the synthetic opioids because they are much more potent than heroin. Fentanyl is 50 times more potent than heroin. And carfentanil is between 500 to 5,000 times more potent than heroin. So what is the advantage? The advantage is, number one, by the fact that you have much higher potency. If you are bringing the drugs into smuggling the drugs, you need a much smaller volume than if you are bringing heroin. And those, it's much easier to smuggle into the country. And in the United States, for example, one of the main sources of entry for the fentanyls is through the mail, which had not been the case, or it would be extremely difficult to do if you're dealing with heroin. And another advantage of these synthetic opioids is you don't have to cultivate anything. You can produce them from scratch. And the synthesis of fentanyl is a relatively easy one. And therefore, the margin for a return on the dealers of these drugs is gigantic. And they are much harder to actually be able to confiscate. And thereupon, I bring it into the notion of, we became complacent in the United States because heroin had started to sneak into us at the beginning of the 2000s. And we were really not very aware of what was happening. We were aware, we were by the numbers that people were abusing prescription opioids, but we weren't paying attention until the number of fatalities just kept on rising and rising and rising. Now we can no longer ignore it. But by the time we're actually losing, in average, in 2016, there were 64,000 overdose deaths in the United States. And you can see it for these ones here. For example, in the case of the fentanyls, in 2016, we have 20,000 people dying from fentanyl, when we had basically none a few years earlier. So this is the speed at which these drugs can end and disrupt the country. This just gets you the idea about the concept of how the requisitions. This is the number, the amount of drugs seized by DEA that were tested positive for fentanyl from 2015 to 2016. And you can see how incredibly rapidly they go. And the problem with fentanyl is because it's such a high affinity for the mu-opioid receptor, and it also gets into the brain very, very rapidly. It is actually producing overdoses much faster than even with heroin. So when the first responders arrive, they find and they report that many times they find the individual already dead, even though they still had the syringe in their arm, making it an enormous challenge for those responders to actually recover individuals that are overdosing with the use of naloxone. And this, again, the other aspect about it is that fentanyls are not, they didn't enter the market as pure drugs, but they are being used to lace, most frequently heroin, but also they are being used to lace other drugs, including benzodiazepines, including other opioid prescriptions, including cannabis. And this, I don't have the numbers here, but if you were to look at the rate of overdoses in the United States from these other drugs, you can also start to see, for example, a very significant increases in the rate of overdose fatalities from cocaine that are likely to be driven in big measure by the fact that they are being laced with fentanyl. So what is it that we as an agency, NIDA, as part of the NIH and the NIH as a whole, put forward as a plan to addressing the opioid crisis? And this is the plan that we put forward more than 10 years ago, where we clearly recognize that if we did not address the need of more research into pain itself, understand it, and in particular chronic pain, and ask the question, what is it that makes a person suffering from the same insult in one instant recover completely and have no pain, versus someone else that suffers the same insult and remains with pain even though the condition that produces it is not longer there? What are the changes that producing that sensitization to the pain condition that results in chronic pain? And why is it that individuals with substance use disorders, for example, are so much more vulnerable for chronic pain conditions? Why is it that patients suffering from a mood disorder are also so much more vulnerable for chronic pain conditions? Why is it that women are much more vulnerable to chronic pain conditions than men? These are questions for which we have no answers. And yet it is fundamental, because without that knowledge, it makes it very hard for us to do interventions that can prevent the transition from acute to chronic pain. A part of that, of course, there's an enormous amount of research that can be done towards looking at targets other than the opioid system, or to work with the opioid system, but in ways that are safer than the ones of the current medications. And so in the top of the triangle is pain. And in the base, we have those interventions and that research that will lead us to better treatments for opioid use disorders, to better prevention strategies for opioid use disorders, as well as interventions that will lead us to prevent overdoses and that will lead us to actually be more successful on reverting overdoses on opioids. In the world of pain, there's some fascinating research, some of it basically being driven actually by work that has been funded by NIDA, to try to understand how is it that opioid ligands, such as morphine, interact with a mu-opioid receptor. whether it is for their rewarding effects or their analgesic effects. And with the development of cryo-electron microscopy, for example, it is now possible to investigate the structure of your receptor when it's bound to the ligand. And it changes, the ligand changes the structure, the three-dimensional conformation of that receptor. But what researchers have found is that different ligands change it distinctly. And this distinct conformation, in turn, results in different intracellular signaling cascades. And here we have two examples of what is now considered, described as a bias agonist, where one agonist, such as typically you have something like morphine. Here you have morphine binding to the receptor. Its conformational change leads to activation of G protein, which is an intracellular signaling that then results in analgesia. And this conformational change also activates beta resting that results in internalization of the receptor and is responsible for tolerance and for the decreasing respiration. Some of the side effects are associated of opioids by this beta resting pathway. And by the way, fentanyl is very effective in actually activating this beta resting pathway, which may be one of the reasons why it is so effective in producing respiratory depression. On the other hand, then researchers are starting to develop, based on computations and the knowledge about what are the binding domains that determine one conformation to another, drugs that will bind to the receptor but will only activate the G protein signaling that is involved in analgesia. And in this case, this drug, Travera 130, is on phase 3 clinical trials at the Food and Drug Administration for an indication, it's being seek an indication for the management of pain, with the idea that this will be an analgesic that is as effective as other opioid agonists, but will have decreased side effects. It will basically have a much safer profile. We will find out what the results determine. We do know from animal models that other investigators working with similar type of concept, the bias agonism, have actually drugs with very good analgesia that produce minimal respiratory depression. A big challenge, though, has been to produce opioid agonists that are non-rewarding. And here, for example, the research towards looking at drugs that bind to the mu-opioid receptor when it forms heteromers. So that means that receptors do not necessarily act in isolation, but they marry with one another. And when they marry with one that is distinct from themselves, we call them heteromers. And we now recognize that heteromers are actually important ways by which cells signal with one another. And so research into seeking out drugs that will bind to heteromers that are not present in, for example, dopamine reward regions give us the possibility of developing opioid drugs, in principle theoretical, that will not be addictive. But again, that has been demonstrated in animals, and much more work needs to be done before we bring it into humans. Another very important area on the management of pain, but also on the management of addiction, is that what we called and has been spearheaded by cancer, precision medicine, the ability to actually tailor an intervention to the unique characteristics of an individual. In the case of opioids and the mu-opioid receptors, we know that there is a rare variant that actually is associated with a higher risk for opioid addiction. It's associated with a higher likelihood of responding to medication with an naltrexone if you are an alcoholic, and has also been associated with a higher risk for respiratory depression. And this variant in the mu-opioid receptor gene, for example, has also been shown by imaging studies that it leads to a much lower concentration of mu-opioid receptors. And it may be that low level of signaling that may, for example, may make these individuals more vulnerable to addictions such as opioids, but perhaps also alcohol. And when you think about it, one of the big question marks that everybody asks is, if you're going to be treating someone with an opioid medication for analgesia, could there be a biomarker that leads you as a clinician to determine whether that patient is at risk of becoming addicted or not. And I would like to say you at this point, yes, we have these gene markers that can guide you. We're not there yet, but we do know clinically that there are characteristics that should alert us about the potentially higher risk of someone to become addicted. And those are, number one, whether they have had a past history of addiction in themselves or in their family. Number two, whether they have a history of mood disorders. And number three, if you are dealing with an adolescent who's actually much more vulnerable to addiction. So clinically, there are certain characteristics of patients that should make us aware that they are at greater risk and therefore be able to do a more proper, closer surveillance. But then let's go back to the base of the triangle. Let's go to the opioid use disorders themselves. Where are we and what are the challenges? Well, in the case of opioid use disorders, we're very lucky in that we have 3 different classes of pharmacological agents that have been approved at the FDA in the United States for the management of opioid use disorders. The 3 classes of drugs, actually all of them interact with the mu-opioid receptor, but they have different pharmacological properties. The oldest of them all is methadone. It's a full agonist, and that means basically it's signaling, intracellular signaling. When you actually activate the receptor, it's going to be maximal, just as you have maximal agonism with a drug like morphine. Then you have partial agonists like buprenorphine, and that means that even if you occupy all of the mu-opioid receptors, that intracellular signaling cascade is never going to reach maximal effects, as is what you see either with methadone or with morphine. And then you have the antagonists. These are drugs that sit in the mu-opioid receptor but do not activate intracellular signaling cascades. They are devoid of an effect. So their action in principle is to interfere because they have very, very high affinity for that receptor. They sit there, and their action is to interfere with the activation by the opioid agonist. In addition, as research has been ongoing, we've come to recognize that apart from these effects in the mu-opioid receptors, these drugs also have other actions that are likely to make them therapeutically beneficial. In particular, buprenorphine, as well as naltrexone, are not only acting at the mu-opioid receptor, one as a partial agonist and the other as an antagonist, but both of these drugs have a very high affinity and act as antagonists at the kappa receptor system. And this is therapeutically relevant because with repeated administration of opioids, just as is the case with repeated administration of alcohol, and presumably also with cigarette smoking, you generate an upregulation of the kappa system. And the kappa system, just like the dopamine D1 and the D2 oppose each other, the kappa system opposes the mu-opioid receptor system. And whereas the mu-opioid receptor activation, apart from having analgesic effects, has antidepressant-like properties, the kappa activation is dysphorigenic. And in many instances, as has been eloquently described and studied by George Koob in animal models, it is the upregulation of this distress system that leads the person or the animal to inject the drug in order to overcome that dark side of addiction. And when you actually go out and ask patients what it is that, based on their own experience, they think is the main cause of relapse, what they will report is not so much craving, which is very important, but actually even more important than craving is depression. So to the extent that both naltrexone and buprenorphine actually are blocking the kappa receptor receptor, this could underline some of their mood-enhancing effects that in fact have been reported in opioid users that have been treated with either drug alone. Regardless, not every patient responds to buprenorphine, and not every person responds to methadone, just like not every person responds to naltrexone. So the ability to have access to these 3 medications increases the likelihood that we will be able to properly treat the patient on the basis of their needs. All of the studies that have been done, whether they are done in Europe or they have been done in the United States or Canada or other areas of the world, have consistently showed that these medications significantly improve the outcomes of people with an opioid use disorder. They prevent relapse, they decrease the use of heroin, they actually prevent overdoses, and that was eloquently shown here in France, where the uptick of the buprenorphine was in parallel associated with a significant decline in the number of overdose fatalities from heroin. And that has then subsequently been replicated in the United States. And they also improve social outcomes, professional outcomes. In the United States, one of the side effects of this crisis is we've seen a 5-fold increase in number of infants born with neonatal abstinence syndrome. And what the studies have shown is if the mothers were treated with methadone or buprenorphine, the outcome of those infants is significantly better. So it improves neonatal abstinence syndrome. So whichever parameter that you look at, there is a significant improvement. So then what is the problem? The problem has two phases. One of them is even though the medications are there, they are not being implemented. And in the United States, less than 30% of individuals with an opioid use disorders that would benefit from medication are given access to this medication. And when they are given access to this medication, they are given access to these medications not for the sufficiently long period of time. That's one. Second problem is that even when they are initiated in medication-assisted treatment, 50% of patients, whether it's methadone, whether it's buprenorphine, or whether it's naltrexone, 50% will relapse within 6 months. So that's the second challenge. And the third challenge that we're facing in the United States is even if we got rid of the stigma that currently exists, where the belief is that you're just changing one drug for the other, and it permeates, what's interesting is it permeates not just the lay public, it permeates the healthcare system, and it permeates the specialty treatment programs. But even if we got rid of that stigma and all of the treatments programs that we have were willing to prescribe this medication, we will not have sufficient treatment programs right now to accommodate for the needs that we're facing in our country. So we have a problem of basically improper utilization, high relapse rates, and insufficient infrastructure. And so when you try to map out the cascade of care, just like it has been done on HIV, where you initiate with a number of estimates of people that are suffering from an opioid use disorder, and this is opioid use disorder severe, not just opioid use disorder, severe. We have approximately 2.4 million people in the United States. And when you look at those that are medication-assisted initiation, you can see it goes to something like 350,000. And then those that are sustained for 6 months, I don't actually know, it's less than 200,000. And that gets you an idea of the severe gap that we have. So we have a gap in changing the way that we treat patients with an opioid use disorder. We don't have sufficient infrastructure, so we need to take advantage of the healthcare systems that we do have and train physicians in order to properly prescribe them. But we also need to recognize that there could be also place for alternative medications that will make it easier for patients to be compliant and would provide alternatives for those who don't respond to these medications. So in the area, so the National Institute on Drug Abuse for many years have made one of its priorities facilitate the development of medications by partnering with pharmaceutical industry so that they can de-risk the compounds for them and they take them up into the clinic. We intercede with them with the Food and Drug Administration. We do whatever it is necessary in order to be able to bring the products to the market. And these are two examples of recent products that came where NIDA was intimately involved. One of them is the extended release naltrexone. That's the 1-month formulation that it goes by the name of Vivitrol. And this is the data, the clinical data that was obtained in Russia that shows the significant impact of extended release naltrexone as it relates to the ability of preventing heroin use in these individuals, as assessed by negative opiates in urine. A very significant effect. And then to the right is a product that we developed in partnership with Braeburn Pharmaceutical that delivers 6 months of buprenorphine at the equivalent dose of 8 milligrams. It's an implant, and in the United States, it has had limited penetration because there are only less than 30% of patients that are on buprenorphine require doses of 8 milligrams or less. So the relatively low dose of this implant has limited its usefulness. But for those individuals that actually can respond to this dose, it ensures that they will not stop taking their medication. It will facilitate compliance. These are two products, and one of them you may already be, many of you may be very aware of them. These are one of them to your left, the 1-month buprenorphine that was developed by Indivior, and that was approved by the Food and Drug Administration at the end of November of last year. And it comes in two formulations. One is a 300 and 100 milligram, and the other one is a higher dose, 300 and 300. And it offers a significant advantage of here. Obviously, you're seeing it with placebo, significantly better outcomes. But when you look actually at the data of the consumption of opioids for those that were on the extended release formulation, it is fascinating because it is actually significantly better than that of the immediate release buprenorphine. Because the question, that I do not know to what extent you are all familiar, in the United States, for the Food and Drug Administration to approve a medication for substance use disorder other than alcohol, we have to demonstrate abstinence, that is, negative urines. But the reality is that some of these medications may be very beneficial by decreasing the amount of drugs that you are given, that the person is taking. The higher the doses they take, the higher the risk of overdose. And these extended release formulations may actually offer advantages over the immediate release buprenorphine in this respect. And this has to do with the fact that they lead to much more stable doses of buprenorphine. And it is probably the lowering of the doses that may trigger the craving that makes some of the patients that are on buprenorphine seek out heroin. The other product is a product of Braeburn, and it has two. One is a 1-week formulation, and the other one is a 1-month formulation. We had hoped that the FDA would have approved this medication at the beginning of the year, but they had some more questions, and hopefully this medication will be approved very soon. In the meantime, we are funding researchers all over the United States, in several places in Europe, in other areas of the world, to actually go after different targets. As we've done research into what are the changes in the brain on a person that is addicted, we've come to realize that there are multiple circuits that are harmed by the use of drugs and that are intimately involved in the presentation of addiction. Yes, there is a decrease in the function of the reward system, and you saw the decreased release of dopamine and the reduction on the dopamine D2 receptors, and this makes these individuals vulnerable to drugs because drugs are potent rewards, whereas the other rewards are no longer able to stimulate them or engage them. But it also engages the learning memory systems that result in conditioning. And it is conditioning that leads them to crave the drug and to frequently relapse. And that, again, generates different areas and circuits than those that are directly involved with the reward system. And finally, as I mentioned to you, the downregulation of the dopamine D2 receptors interferes with the function of the prefrontal cortical regions that are necessary for self-regulation and control. And so this pattern is what is responsible for the repeated role of addiction that goes from binge intoxication to withdrawal to craving and again relapse. And this constant relapse rate, which makes it so very difficult for patients to be able to recover. So researchers are with this knowledge, are going after targets that can modulate these different circuits. We're also promoting research to the use of whether transcranial magnetic stimulation or to direct electrical current stimulation to target specific areas that can basically strengthen the function of those circuits that are disrupted in addiction. And some of the most interesting work in this respect has been to studies that use TMS, transcranial magnetic stimulation, in order to strengthen the function of the prefrontal cortex. And studies that have been done in alcohol, in cocaine, and nicotine show preliminary positive results indicating that not only decreases craving, but it actually may be able to decrease drug consumption. We're also working on the development of vaccines against heroin, vaccines against fentanyl, the development of monoclonal antibodies that are long-lasting. And the idea of these interventions is that the antibody would bind to the drug in the blood, interfere with its entrance into the brain. By interfering with its entrance into the brain, it therefore blocks the reward. It therefore blocks the respiratory depressant effects of heroin or fentanyl. It has been very challenging because the vaccines that have been generated and tested in humans have not been sufficiently antigenic to produce the titers of antibodies necessary to effectively capture the drug. There are new strategies being followed, but another very, very exciting and potentially perhaps more successful strategy is that of using passive immunization with monoclonal antibodies that are long-lasting. And then the other component, which is the one that I was mentioning and I want to bring up forward, just that to the extent that we are developing models of care that may be of value in other areas of the world, including France, is how do we engage the healthcare system in being more proactive in the screening and the treatment of individuals with an opioid use disorders. So this was a paper initially done at Yale University where they showed that in initiating buprenorphine on patients that have an opioid use disorder in the emergency department itself significantly improved that outcome on that patient, as opposed to referring them to a buprenorphine clinic or to a physician to follow them up. That simple early initiation significantly improved outcomes. Now that we're going to have access to 1 week buprenorphine, this will actually is likely to lead to even strengthening the impact of this intervention. We're similarly working with primary care physicians with models that will allow them to engage on the active not prescription of buprenorphine, but also models that will allow nurses to help with the oversight of these patients, and with very, very good outcomes. And finally, certainly in the justice system in the United States, it has been very, very difficult to penetrate the utilization of medication-assisted treatment in jail or in prison. Even in some of the parolees, it has been very difficult to convince the justice system to actually engage on medication. And this is starting to change, and in grand part, I think that the access to antagonists, which are more amenable for use in the criminal justice system, and with the access of a 1-month formulation, you can actually start to see the significant improvement you can see here for Vivitrol. This is a study that was done at Philadelphia. Chuck O'Brien was the senior investigator showing the effectiveness of Vivitrol in this justice population. But look to your right. Whereas there were 7 overdoses in those with treatment as usual, there were 0 overdoses in those that were treated with extended-release naltrexone. So here is where we are. We are actually at the basis of understanding addiction. We are in an opioid crisis. Yes, it's the worst that we've had in the United States, but it's not the only one, and it's not the only one in the world. Drug addiction is something that actually has existed throughout civilization. And we, of course, can pinpoint the overprescription to the opioid crisis. But the question that we need to make ourselves is what was there in America that allowed the crisis to proliferate so rapidly? Initially with opioids, then with heroin, then with fentanyl. What is it that attracted the drug dealers to go to these areas and disseminate their products? That we had a vulnerable population. And I think that, again, as we're discussing the issue of addiction, we need to recognize that component of addiction. Drugs change the human brain in ways that actually lead to disruptive behaviors that actually make the person lose control of their self-regulation. But there is a component of prevention that entails significant socioeconomical factors. And I bring those 2 graphs because it's the 2016 graph for drug poisoning deaths in the United States, and the one for all ages in poverty. It is very heterogeneous map, but there is a strong correspondence between poverty in the United States and the areas that have been most affected by the opioid crisis. It's not a one-to-one correspondence, but there is a very significant areas that are the most deprived, such as the Palestinian area, are some of the ones that have the greatest rates of mortality. And I think that we've recognized that all along in epidemiology, that indeed social factors are strong determinants of vulnerability for addiction. Through studies with neurobiology, we're starting to understand why is it that social adverse environments that are very stressful make individuals more vulnerable to addiction. And these are two different sets of studies, one done in monkeys, in which it actually shows that when you have an animal that is a subordinate, which is a very, very stressful situation for a primate, there is a downregulation of the dopamine D2 receptors. And that downregulation of the dopamine D2 receptors make these animals vulnerable for compulsive administration of cocaine. And in humans, we've also been able to see that kids that are raised in orphanages with a lot of social deprivation also have abnormal development of the connections of the prefrontal cortex with the limbic areas of the brain that are necessary for self-regulation. The longer the history of deprivation, the slower the formation of those connections that ultimately are necessary for us as adults to exert complete control. More recently, a paper that was just published 1 or 2 months ago, done in adults, because we've come to recognize that particularly nefarious is adverse environments during childhood and adolescence. But what was very intriguing about this particular study is that it showed that social stressors, in this case, as assessed by low socioeconomic status, that includes not just your the amount of money that you make, but very important, your education, in adults, middle-aged adults, significantly affected the human brain. And they showed both that in those individuals with the lower levels of socioeconomic status, the lower levels of education, have the greatest level of cortical atrophy. These were middle-aged individuals that otherwise have no evidence of other medical pathology, illustrating how important is the social environment that we work on in ultimately influencing our brains, which ultimately influences who we are and our behaviors. I want to end up with this because the crisis is extraordinarily tragic, and it has that human component of desolation that has led Dayton to describe overdose fatalities, addiction, suicide, alcoholism as the diseases of despair. And as we think forward and we address the notion, what is it that we can do in terms of prevent addiction, apart from treating it, is we need to recognize that we need to address that social determinants that are making people so vulnerable to these drugs. Thanks very much for your attention.
Merci beaucoup, Nora, pour cette présentation démonstrative, documentée, instructive et, as usual, brillante, et qui ouvre très heureusement sur les perspectives de prise en compte des déterminants psychosociaux. Et je pense que c'est l'occasion maintenant d'un débat passionnant, et donc on peut passer la parole à l'auditoire. Qui veut intervenir? Question?
So thank you, Nora, for that nice presentation. We know that fentanyl is now into the other drug supplies, the cocaine and the methamphetamine. Do you think the reason is to create more opioid addicts? Because so many people are dying because they have no idea that fentanyl is in the product. Do you think that's the reason they're doing this?
Marilyn, I had not thought about it. I asked myself the question, how is it possible that there could be such an effective distribution of this fentanyl so rapidly across the country? And so I say, am I becoming paranoid? But I hadn't thought about it in this other way, and certainly we we don't know how frequent it is, and if we start to see it in more systematic fashion, you could conceive that, yes, this is a way of making people addicted to opioids, and then you're going to have the need, that person will become addicted, and then you expand your market. That is a possibility. At the same time, the other side of the coin is that some of these drugs are so toxic that they are killing the potential clients, right? So it is like one of those infections that is so lethal that it kills the person, but it also, the virus no longer has any place to go. So it's unclear at this time. I think that we need to be observant that whether that is the case. But the reality is, whatever it is, there has been no unprecedented dissemination of a drug so rapidly with such a level of penetration. We've never seen anything like that.
Yes. I would like to ask you two questions. The first one is, now in the United States, are there advertising in the media for opioids, as it happened for many years? And the second is there a test when you buy heroin in the street, when you buy heroin on the black market, even in the street or on the internet, is there a test to know if there's fentanyl inside the heroin you have bought? I saw things about that, but I have no clear vision of the problem. It could be very useful.
I agree. And well, let me ask first the first question. Currently, there are no advertisement of opioids in the television in the United States. There is advertisement against remedies for constipation from opioids, but not against the opioid itself. And as you know, the United States does a lot of advertisement of pharmaceuticals, and that sets it apart. And it has been shown that it does influence the likelihood, if someone watch an ad in the television, that they will bring it to their physician, and therefore they have a higher likelihood of being prescribed. So that is an issue that has all along been problematic. But as of now, there is no advertisement on opioids. With respect, are there a way of determining if there is fentanyl in a drug? And there is a product that was developed, a strip, in Canada that allows you to do that. At NIDA, we're funding to actually small businesses to develop such a product such that the person can rapidly test whether the drug that they are buying contains or not fentanyl. But there's already that product that you can get with Canada. We just want to diversify and make more products available. And we also want to get a product that may have more quantitative information, not just present or not present, just for purposes of understanding the epidemiology. One of the big challenges that we get is that, for example, right now, the data that I showed you is 2016. I don't know what's happening in 2017. We do seem to know, because there's a very large delay in the reporting of the overdose fatalities. So to be able to have ways of measuring right away that could be entered so that we all in a community could find out when opioids are being laced with fentanyl rapidly, having that product would also be very helpful for that perspective, not just for the users, but a community trying to actually rapidly respond when there is evidence that fentanyl or other analogs are permeating their market.
I have a question related to, I have the feeling that we have a lack of data about the sociological aspects. Who is really dying? What are the characteristics of the people at risk, etc. For example, now you presented about this coincidence between the map of poverty and the map of overdose. Now, I'm fully convinced that yesterday presented about the effect of stress and poverty in childhood on the brain, and I'm fully convinced by this. But the brand and the publicity or the fake news about the opioid crisis in the US now is presented such as a phenomenon of the middle class, something that affected not the marginalized but also the normal people with a normal job alone.
Yeah, no, and I was interested, and this is a complex issue because the opioid crisis started to hit not middle class people, but white Americans, poor white Americans. No, it is in the rural areas. It started as a rural problem, Appalachia, New Mexico, and that's where you still have some of the worst situations. Kentucky, West Virginia, Tennessee, New Mexico, those. Now, what is happening is that from being a predominantly rural problem, it went urban. And from being a predominantly area of white poor people, it's going into actually northeastern states. And northeastern states are being hit very badly because the fentanyls started to emerge in that area. So for example, in New Hampshire, in Maryland, in Maine, you have over a period of 2 years or 3 years, doubling the number of overdose fatalities, and it's basically driven by fentanyl. In Massachusetts is a state in the northeastern, also with very, very high rates of mortalities, where at least 80% of the deaths are associated with fentanyl. So that has changed from the poor whites. Now it's actually, you start to see even in African Americans. So you are seeing the number of fatalities going up in African Americans. And it's also discussed, what you see in the media, that it's also affecting middle Americans, because you are seeing people that are being prescribed opioid medications who had never, ever used any drugs, becoming addicted to their medications. And so that has opened up to the whole change in the sense that, oh, it's them, that demographic, it's not us. Because now we're seeing it, basically almost everyone has been affected by the opioid crisis by different routes. Because you're a pain patient, they prescribe you. And guess what? If you're middle class, you're much more likely to be prescribed an opioid than if you are poor, African American or Hispanic. Much less likely to be prescribed an opioid. That puts you at greater risk. But then on the other hand, if you are in the Appalachian region and there are not many jobs and you have a job that actually hurts you, where there's already a lot of problems with alcohol, then access to these opioid medications is very fast because they're very, very rewarding. And then there's, of course, this black market that's bringing the heroin and the fentanyl. So we started with a more clear perspective of rural areas, then it went into urban areas, and now it's everywhere. Poor white people now is basically almost all demographics, including African Americans.
Thank you very much for your impressive talk. In France, we have today about 40 times less overdose. And I'm terribly anxious because, you see, we always copy what our American friends do. And we can say the pain, the fight against pain has been very well implemented. The substitution is a very particular French system with a very high level of access to substitution for drug users, and a free system. And then the naloxone is now allowed. So I think those three issues you showed us very clearly are attempt. What is going to happen? Black market, internet, blacknet, and fentanyl. So do you have recommendation to do to stop this epidemic that we might have?
Well, I think that I brought it up specifically for this because I think that you all, who are basically the ones that are dealing with people suffering from addictions, are going to be the first one to be able to recognize if, in fact, you start to see changes in the rate at which people are becoming addicted to opioids, or there is an increase in the overdoses, or there is an increase in the injection patterns. Looking for it is actually fundamental. And there should be also a surveillance system that it properly is evaluating what is the cause of overdoses. We started to notice it because you see, I mean, as the curves were going up with prescription opioids, but then they just go up pretty dramatically. I mean, and right now we are increasing overdoses on a yearly basis by 22 to 24%. So when you see a change in the pattern, that should make you very nervous. And we should not be, I think that the answer is do not become complacent. Because yes, the United States is a country that does consume a lot of things, including drugs. But there is now this contagion effect that through all of the media that can rapidly make one behavior go into another one. And as I mentioned, Canada is also suffering with fentanyl overdoses is not just limited to the United States. So being aware of it and being proactive from the perspective of prevention, and that's why I wanted to end this way. That at the end of the day, the most important thing that we can do as a nation or as the world is to do interventions to prevent the use of drugs. That's the most valuable and impactful thing that we can do. And that means, of course, addressing some of these issues that lead to despair, that makes people vulnerable to taking drugs.
What is the explanation for such a low level of medication-assisted treatment in the States compared to other countries?
Unfortunately, there's a lot of stigma against medications. Most of the treatment programs in the United States are actually not born out of the healthcare system, but individuals who themselves had been addicted in the past and who have been able to recover with the use of medications with very strong ideologies that oppose the use of a medication because of the misguided belief that because it's interacting with a myopia receptor is another drug, without a proper understanding that it has very different behavior than the drug itself, and without understanding also the context of what addiction is and conditioning and basically the pharmacokinetic components of this process. That lack of understanding and the fact that it has been brought up as a separate from the healthcare system has made it very, very difficult to permeate. And then that's another element that has not helped is that until very recently, insurance companies were not paying for these treatments. So if I am a doctor and I'm going to be treating someone, but I'm not going to be compensated for treating that person, it's very unlikely that I will do it. Plus also I don't get training, and that is another, has also been a major challenge, that in medical schools there is very minimal education for medical students about what substance use disorder or how to manage. That is starting to change now that they recognize that we need the healthcare system to become involved. And I would hope that one of the aspects that will come out of this crisis is that in the United States, the treatment of substance use disorders is being given by the government, and the government gives money to the states, and the states distributes the money. But there's no demand for quality of care. So you can set up your clinic and say, I'm treating these persons with no evidence that what your intervention is effective, and yet you will be reimbursed for that treatment. So one of the aspects that we're trying to change is how do we generate metrics that would allow us to determine the efficacy of a treatment program in helping an individual with an opioid use disorder, to evaluate that particular treatment does have the elements that evidence base has shown to be the ones that are more likely to lead to success. So we're developing those metrics in order to be able to generate a system with reimbursement is based on outcomes. So that has been a major problem.
Thank you.
Dr. Volkow, thank you very much for your great presentation. I am always very surprised to see in the US that the detoxification programs are still very strong. In fact, I was reading recently that I think the sales of the MAT treatments are about $2.5 billion, when the sales and revenue of the detoxification programs are estimated to be $37 billion. How do you explain that, and what is the NIDA doing to, spread the science, and as you just said, incentivize the quality care and force the insurance to reimburse, proven evidence-based treatment rather than detoxification programs that have been shown consistently to fail patients and system?
Yeah, no, and I think that there are many studies that have shown independently that there is a much greater likelihood that you die if you go through just a detoxification program and there's no medication-assisted treatment to sustain you. And in very different settings. There's just a paper that was published the past week on the Journal of Internal Medicine, which shows that individuals who were on an emergency department, they followed them for 12 months to see if they overdosed. And these are individuals that were in a healthcare system where there was an opportunity to intervene. And what they showed was on those that were given buprenorphine or methadone, the likelihood of survival was 3 times higher than those that were not. And this was even though the intervention was not sustained for sufficiently long period of time. So no matter where you look at, you can see the effects are pretty large. So the question is, what is it, how do you change that culture when it's so ingrained in people? And one of them is, obviously, I always think that the data should speak for itself, but also to start to develop, we are partnering with an organization in the United States called the Addiction Policy Forum, which is the largest patient organization of addiction in the United States. It has 4 million members, and they are going to be generating a website called like a Yelp, like when you go and you want to see, you don't know what hotel to go to when you want to go to France, you can go there and see the ratings. So they are going to do something similar so that the patients and their families can rate their experiences on the treatment program and they can look into them. And that system will incentivize those programs that are not getting good marks to do better. So that's one system. And on the other one, we're working with the insurance companies and with the agency, which is SAMHSA in the United States, that provides the money for the treatment to, again, generate what we call report cards to evaluate treatment programs on the basis of the characteristics and how well the patients are doing. And we're also working with insurances, because a part of the problem in the United States has been, even though there's the parity law, and even though it is illegal not to provide treatment with medication for someone in an opioid use disorder, there are too many roadblocks in order to do so in many of the states. You have to fail first. You have to relapse first before they give you the medication. The problem is you can die when you relapse. And even if they give you the medication, they give it for relatively short period of times, and then they give one medication or not the other. So there are too many barriers on the way that the parity law is being implemented that actually requires revisioning. These practices need to be brought to the attention because they are illegal. It should not be the case. But they have made it very, very difficult to change the attitudes.
Question?
Many thanks for your talk. I have a pharmacological question about fentanyl. Don't you think that the availability of immediate release of fentanyl have been a very dangerous decision, because with some slow release such as patches, perhaps the epidemic we observe with fentanyl never arrived?
Well, I think that fentanyl was predominantly initially released, if my knowledge is correct, to be handled by anesthesiologists, and it's a very valuable drug when for anesthesia purposes, or in a situation of a surgical procedure, predominantly in the hospital. When they release it for outpatient care, that was with the intention of trying to help patients who have, even on high doses of opioids, still have pain, for breakout pain. The extent to which that was diverted, some of the products were diverted. There were some lollipops that then actually became very, very, very favored in the black market. But this fentanyl that we're seeing is not that therapeutic. So it's hard for me to know overall, without having the number of and outcomes of those individuals that were prescribed fentanyl for their pain on an outpatient basis, what happens to them. I do not have sufficient knowledge to comment on that. But the fentanyl itself, these fentanyls are black market. They're not therapeutic.
Bien, je crois que l'heure est venue donc de libérer Nora, de la remercier d'être venue jusqu'à l'Albatros et de remercier Amine Benyamina de l'avoir convaincu de venir et de la qualité de tout le congrès. Enfin, je crois qu'il veut faire un rappel d'agenda pour demain matin pour rappeler qu'à 9h, il y a rendez-vous sur les pistes pour donc parler de la prévention à travers la médecine par l'épreuve. Donc on est tout à fait dans le vif du sujet. Donc, encore une fois, merci beaucoup Nora, et à très vite, à demain.